Well, hello, everyone, and welcome. My name is Darren Arthur, and I'm an oncology clinical social worker at Mount Sinai, Union Square, and Chelsea Cancer Centers, and I will be moderating today's panel of presenters and also presenting as well. I'd like to thank Eduardo Colon, our AV analyst from our audio visual department, our digital tech department, who will be helping us with the presentation today. Our goal is to explore common concerns of patients with head and neck cancers related to post-treatment and beyond. We have assembled clinicians from various backgrounds who will speak to concerns they most often hear from patients and caregivers. After all the speakers have presented, we will have time to take questions from you viewers. We could easily spend an entire hour just on any one of these common concerns, but for today's purposes, we want to highlight ones that are most often brought to our attention and ways to think about and to address them in a more positive and healthy manner. So I'd like to thank our distinguished presenters for participating. And to start us off, I'd like to turn it over to Ashley Taylor, who is our Speech and Swallowing Clinical Fellow, and joining her are her colleagues, Cindy Gans, Manager in Speech Therapy, and Alexandra Chill, Speech Therapist, all from the Mount Sinai Union Square Head and Neck Institute, the Department of Otolaryngology Head and Neck Surgery. Go ahead, Ashley.
Okay, thank you, Darren. Great. My name is Ashley Taylor, and I am a speech pathology fellow specializing in swallowing disorders in head and neck cancer patients here at Mount Sinai. I am joined by my colleague Alex Chill and our supervisor Cindy Gans, and today we'll be discussing dysphagia in the acute and long-term periods after radiation treatment for head and neck cancer, and our roles as swallowing specialists throughout the treatment and post-treatment course. So first, what is dysphagia? Dysphagia is defined as any difficulty swallowing food or liquid. So this could look like frequent coughing and choking, feeling like food is sticking in your throat, having trouble manipulating food in your mouth, or any other swallowing related difficulties. However, patients who have had chemoradiation may be unaware of some of these issues due to impaired sensation in the throat as a result of treatment. Swallowing efficiency is the ability to move food from your mouth through your throat and into the esophagus or the food pipe. When we talk about swallowing safety, we're referring to your body's ability to protect the opening to the airway and making sure no food or liquids get into the lungs when swallowing. In more severe cases, escape of food or liquid to the lungs could lead to respiratory problems over time. On this slide, we have a video of someone swallowing liquid on X-ray. And so as you can see, the black material is the liquid and it's passing through the mouth into the pharynx or the throat and down into the esophagus, which is the food pipe. And it's hard to see, but there are several muscles in your mouth and your throat that protect your airway while moving the food and liquid into your food pipe. Many people who undergo chemoradiation treatment for head and neck cancer experience dysphagia during or after their treatment. This may be caused by a structural change in the mouth or throat as a result of the surgery, the cancer, or due to the effects of radiation treatment, which include dry mouth, thick saliva, pain in the mouth or throat, and taste changes. Also, during chemoradiation treatment, it's possible to experience what is called muscle fibrosis or weakening of the swallow muscles. So our role as swallowing specialists is to evaluate dysphagia and provide you with strategies and rehabilitative exercises to maximize function of the swallowing muscles to ensure efficiency and safety. The process of training these muscles is done through continuing to eat and drink all throughout treatment, as well as other rehabilitative exercises that target the muscles of the swallow specifically.
Yes.
Your speech and swallow therapist will work with you and establish an appropriate plan that's tailored to your treatment in order to help maintain the swallowing muscles and maximize safety and efficiency. And now I'll turn it over to Alex, who will discuss more about diet, exercises, and following up with your care team.
All right. Hi, everyone. I am Alex. I am another speech and swallow therapist here at Mount Sinai. So I think I'd just break it down for you in terms of the acute post-treatment period, meaning the first about, I'd say under a year, but especially that first month after treatment, and then talk a little bit about some long-term concerns as well. So just starting with that immediate post-treatment period, one of the biggest things that we always say is to continue, first of all, just continue your symptom management as you have been throughout the treatment, as your medical oncologist and radiation oncologist have recommended and prescribed to you. It's really important, those adverse effects of treatment are cumulative, as you, I'm sure, have experienced if you're a patient. The treatment effect is worse at the end of treatment. Those effects will also gradually improve, usually after about 2 weeks post your final radiation treatment. So it is hard to be patient, but be patient and everything will get better, we promise. Again, also, as you follow up with your medical oncologist, your radiation oncologist, the whole care team, you also want to continue to follow up with speech and swallow. For us in our office, we usually see people about a week after, 2 weeks after, and sometimes even bi-weekly for a couple of months, but that is completely dependent on independent facilities. The reason that we want to see you so frequently is to get you back to what's called a least restrictive diet, meaning mostly regular solid foods. Because of those adverse effects during treatment, patients tend to be on a more limited diet, like a liquid or puree. We want to get you back to regular solid food. Sometimes that's not always 0 to 100. It's sometimes more like a staircase model. We actually have this model here that if anyone in our audience wants as a resource, we are happy to hand out. Oops, it's a little tricky to see, I guess, with the reflection. But what it's demonstrating is that the bottom of the staircase is a thin liquid and the very top is a regular solid. So there are many steps in between there, like a puree, like a minced and moist salad, something that's a chopped or a cooked vegetable. And then you get to something hard and crunchy. You're not going to get there right away, but you will get there. In addition to just getting you back to regular solid foods, because that's what patients want to eat usually, you're also you're giving yourself functional rehabilitation for those muscles that Ashley was showing you earlier, for those pharyngeal and laryngeal swallow exercises that help with safety and efficiency of the swallow. Swallowing is use it or lose it. So you really want to use those muscles the way they're intended to be used. And in addition to that, we want you to also continue the swallowing exercises that you've been prescribed by our speech and swallow therapist. So the literature is sort of inconsistent in terms of how and when exactly to complete those exercises. But we do know, as Ashley said, that the radiation can cause fibrosis to some of those muscles and make them a bit weak. The exercises that we're giving you are specifically designed to strengthen specific components to your swallow, and they're tailored to your needs, what specific muscles you need specific exercises on. In addition to that, we also always encourage our patients to continue jaw range of motion stretches. Again, everything can get very stiff in this area. You want to really make sure you're doing those jaw stretches every single day, along with the swallowing exercises and advancing your diet. The whole program is important, which is why we need frequent follow-up. Let's talk a little bit now about more of the long-term impacts of chemoradiation and some concerns that people have. Again, important to follow up. Want to follow up with your speech and swallow therapist. Here we do it about every 3 months after the first year. Again, everywhere is different, but you do want to establish a relationship. The reason for that is we're consistently monitoring for any impairment in that safety or efficiency of the swallow. There is something called late radiation associated dysphagia, which is a progressive fibrosis or progressive weakness in the muscles. It's something that we look out for. It is not something, to panic about, but you want to look out for soft signs of that as well. When I say soft signs, I mean, it might look like clearing your throat more when you eat and drink. It might feel like food sticking in your throat. If you experience something like that, you're going to let a speech and swallow therapist or someone on your care team know, and we will address those concerns. The idea is to not let things progress and become worse. We want to nip it in the bud. All right, you also want to continue to monitor for that jaw range of motion, as I was saying, similar to that immediate post-treatment period. We usually say you want to make sure your mouth is opening at a 3-finger width. So you should be able to stack 3 fingers one on top of the other. Everyone is a little bit different and everyone has a different baseline. So really the idea is to monitor where you are and make sure that you're staying stable or growing larger. You just don't want to get smaller. If you're feeling that your jaw is tight or you're not hitting where you're supposed to be, you know it's time to do some more stretches. In terms of other concerns, in terms of long-term radiation effects, we typically hear people complain a lot about xerostomia or dry mouth. There are over-the-counter products that some people have found good relief with. One is called Xylemelt. Another is Biotine. There's a few different products from that company. One that people particularly seem to like is the Biotine gel. Some people like the product, some people don't. It sort of depends on the person. There may be a component at some point of adjusting, and maybe you're a water drinker now with your meals, whereas you weren't before, using lots of humidification and making sure to keep your body moist. There is new potential medical treatments being explored right now for management of xerostomia. So I hope one day to let everyone know about some new and upcoming research, but we will keep you posted. Just remember to use your speech and swallow therapist as a resource. You're welcome. We have a big care team here. We'd love to answer any of your questions or find someone who can answer them. So I will turn it over now to our next speaker.
All right, well, thank you, Ashley and Alex. And next we have Dr. Andrew Rossetti, who is a music therapy supervisor in radiation oncology with the Louis Armstrong Center for Music and Medicine. Andrew?
Thank you, Darren. Pleasure to be here. And I'd like to tell you a little bit about our program in cancer care here at the Louis Armstrong Center for Music and Medicine at the Mount Sinai Healthcare System. So the Armstrong Center for Music and Medicine has been in existence for about 28 years at this point. It is led by my colleague, Dr. Joanne Lowy, and we have at this point about 10 music therapists. We are all board certified music therapists, licensed psychotherapists in New York State. We also have a team of about 15 master's level interns with us, and also our medical director, who is a psychiatrist. And so music therapy is something that if you have gotten treatment for radiation therapy, you may have already had occasion to be have a session with a music therapist before music therapy treatment during the course of your radiation therapy. For those of you who are unfamiliar with music therapy, specifically music psychotherapy, it is a modality of psychotherapy that uses music and its elements in a therapeutic relationship that also involves some talk therapy to address physical, emotional, psychosocial, and spiritual needs of patients receiving treatment for cancer. So I'd like to talk to you briefly about a couple of things that we work on with patients that we try and address post-treatment, which is often patients, when they've finished treatment, have a sort of feelings of generalized anxiety, something that they feel that they can't quite shake and they can't quite reason through. And so in music psychotherapy, we provide a strengths-based resiliency building program in mind-body interventions to help patients be able to downregulate their state anxiety and to actually be able to use anxiety as a functional tool. And that concept of anxiety being something that might be seen as a functional tool has to do with the way anxiety is sometimes misviewed at this point. Most people think of anxiety as something bad and something that needs to be avoided, when actually anxiety, especially state anxiety, is a completely organic and functional response for the human organism. So anxiety is a somatic experience. It's our body telling us that it is prepared and amped up to be able to take action to address challenges or threats. The problem comes when we are not able to recognize how or how to be able to resolve the threat or the challenge. And so we have this sort of residual somatic experience that feels really unpleasant. So anxiety is notoriously difficult to resolve just by thinking about it, right? Just by using the rational mind. So we've found that one thing that is actually quite effective is to first use a mind-body approach, and I'll explain what that is in a second, to sort of give people resources or tools to be able to downregulate their anxiety. And when this happens, we're able to free up some bandwidth in the rational mind, so the rational mind can do its wonderful work of meaning making and organization. So often what these mind-body strategies have to do with are things like breath focus, music-assisted breath focus, music-assisted visualization. They're very, very effective techniques that can be worked on with a therapist, and the music therapist will also teach you how to do those so that they become part of your repertoire and actually contribute to building resilience. And another issue that comes up quite often for patients is sleep disruption. And so it's often very common, especially in these really difficult times that we find ourselves in, lots of stress, perhaps due to what might be perceived as social unrest, and also, unfortunately, the pandemic, which is still with us. So sleep disruption is often something that happens to many patients, and often they'll describe it something like this. I don't really have difficulties getting to sleep, but I find that I sleep for a few hours, and maybe around 3 o'clock in the morning, I realize that I'm awake. I also realize that I have a very disturbing thought that sort of stays with me, circulates, and is joined by other disturbing thoughts. And at that point, it becomes impossible to seem to get back to sleep. So there are a number of interventions that we can do that are also strengths-based, not only to help patients be able to sleep, but to teach them how to be able to regulate that state so that they are very easily be able to fall back and get restful sleep. And this starts off with something that we refer to. And sleep hygiene is a series of maybe precautions to be taken or habits to fall into right before we go to sleep. So the first is that one of the things that we want to get rid of for about an hour and a half to 2 hours before we go to sleep are anything that looks like this, anything that has a screen. Our phones, our TVs, our computer screens actually emit frequencies that are very stimulating to the brain, and this in and of itself is something that can impair being able to get into sound sleep, being able to access REM sleep at some point. So the first thing would be to ditch your screens about an hour and a half to 2 hours before you're going to go to sleep. The other thing is to not eat a very heavy meal within about 3 hours of going to bed. And the next thing would be to create an environment in your bedroom that is conducive to rest and restful sleep. And that's actually quite easy to do in thought, but maybe not so easy to do in practice. And basically what it is that we want to make sure that our bedrooms do not have any screens, that we don't engage in things that are that we should be doing perhaps in other rooms. I know in New York apartments that's not always the easiest thing to do, but you shouldn't have it. Your bedroom should be used just for two activities, which is sleeping and intimacy. Anything that is different than that should be done in a different part of your house or your apartment. And what that does is help to create a sort of conditioned response that the body recognizes that when it's in the bedroom, what's going to happen is that it's going to rest. So we follow up with patients post-treatment, and we actually work with patients in our clinic, in the Louis Armstrong Clinic for Music and Medicine here at Sinai. And I'm going to pass this on to the next speaker.
Thank you, Andrew. Our next presenter is going to be Brittany Craig, Clinical Nutrition Coordinator here at Mount Sinai Union Square. Go ahead, Brittany.
Thanks, Darren. Okay, hi everybody. So I'm going to talk about a few things that are important or helpful to keep in mind post-treatment for head and neck cancer. The first is that eating well, making sure you're getting enough calories and protein right after treatment is still just as important. I think sometimes we see our patients, you're so focused to just getting to the end of treatment that when you finally finish, oftentimes I hear patients like, oh, I'm just ready to just relax and, not have to worry about this so much. And that makes sense. But unfortunately, you still really need to work to make sure you're getting enough in. Your body needs that to help continue the healing process from all the treatment that you had. And your protein needs still remain quite high for at least a few weeks after that treatment. That's because protein helps us in building and repairing tissues in the body. And especially if you've had radiation therapy, you have a lot of tissue that needs help healing. So protein is your friend in that department. But it is still going to be challenging to eat well after treatment due to the treatment-related side effects and the dysphagia that was discussed about as well. So you have to still work on it and make sure you are thinking about protein sources at meal times and snacks. Protein, of course, can be animal proteins like chicken, fish, eggs, dairy. It can also include plant-based sources, which we'll touch upon a little bit more in a little bit. But it can also help to have protein powders or commercial protein shakes, things like Ensure or Boost or Kate Farms. There's a number of them out there in the market, or making your own smoothies with protein powder as a snack can be really beneficial as well, just to make sure you're getting enough in. As the weeks go on from the treatment, you will start to feel much better. And then it'll be easier to advance your diet and go back to sort of what was normal for you. And your protein needs, of course, won't remain quite as high as soon as, assuming that the treatment went well and you're feeling good. Now, one of the side effects that I hear from a lot of patients that lingers for a while after treatment is dyscusia, which basically means the dysfunction of taste. So taste changes, which can occur from both the chemotherapy and the radiation. They can linger for quite a while for some of our patients. And I know that can be really, really frustrating. You're ready to just get back to your normal diet and enjoy food again. And maybe you don't have much pain anymore and you're swallowing well, but that taste still is just off. So there are some things you can do. First is really trying to keep your oral hygiene well. So, brushing your teeth, mouth rinses, that will help a lot, especially if you still have some thick phlegm or saliva left over from the radiation. Doing a mouth rinse, such as baking soda and salt, in your mouth before you eat a meal might help get a little bit of that phlegm out and help with the taste as well. So if you have no taste, then sometimes my patients tell me they can taste a little bit of sweet, or by adding more spices and seasonings to their foods and more flavoring, it might help bring, sort of stimulate the taste buds a little bit better. If you have a bitter or metallic-y taste in your mouth, which often is accompanied by a lot of the chemotherapy treatments that our patients end up having, then sticking with sweeter things can help as well as sour flavors. We find like sweet tasting like marinades can help, or having maybe even just some fresh fruit if you're able to have that at meal times. If water tastes off, maybe try some lemon in the water or a little bit of lemonade or cranberry juice. That tartness might be more appealing. Also consider having like lemon drops or chewing on gum in between your meals. If there's kind of that gross taste left over in your mouth, it will help a bit. We do promise it will improve. I wish that we could give a time frame for when it gets better. It really varies from person to person. But we do find sort of anecdotally that as long as you're really making an effort to eat and get proper nutrition, that helps the healing process, which might further help the healing of your taste buds. So that's something to keep in mind. And then the other thing I wanted to discuss is for post-treatment, once you're feeling better and on, is the concept of this plant-based diet. You might have heard this term a lot. It's because the more and more research we see is that eating more vegetables, more fruits, more whole grains helps reduce our risk of cancer, and cutting back on animal products, especially red meats, can also help reduce our risk for cancer. So one of the studies, the Nurses Health Study, actually found that just an intake of red meat consumption does increase our risk for cancer mortality as well as cardiovascular disease. So it's something to keep in mind. Now, of course, right after treatment, main focus is just getting in the calories and the protein, whatever that means for you, whatever you're able to do. Once you're feeling better and you're healed and you're able to enjoy your diet again, that's when we really want to start incorporating more plant-based foods into our diet. This by no means it has to be a vegetarian diet. You can still have animal proteins. Just try to have more plant-based options and try to maybe have some vegetarian meals here and there. Some good plant-based protein sources are things like tofu, edamame, beans, legumes like lentils, nuts, seeds like chia seeds, flax seeds, pumpkin seeds, nut butters are great. And quinoa as well is a great grain. It's actually a very good protein source. You can also have lean proteins like chicken, fish is really good for us still, eggs. So don't think again that it has to be vegetarian, just the less red meat in our diet, the better. And that's just something to think about for long term to really try to work on in the post-treatment setting once you are healed. And I will send it back to Darren.
I'd like to discuss 3 common topics and sort of struggles that come up in my work with couples, patients and couples and families, and how it's common and it's normal should they occur for you. And that does not mean that they're going to occur, that they will occur, or that all of them are going to occur, but that they are topics to consider as you navigate through this post-treatment phase. So the first one I'd like to talk about is the possible separation anxiety. What might, why might a patient experience this sometimes? And for some of you, it can be difficult making the transition from frequent, often, daily visits if you're getting radiation to the cancer center for your treatments, to waking up one day and not having to go to the center any longer on any regular basis. And we understand that you might not be excited about finishing treatment because you feel better supported and more comfortable coming in on a regular basis and seeing the staff and having them check in on you, basically attending to your needs. And so when you finish your treatment, it can feel the next day when you do not have to come to the center as though the team has sort of disappeared and that you're now on your own. And, this is certainly not the case. We want you to know that we are, still available to you. And we're going to see you at your next follow-up visits and many visits after that. But many of my patients, certainly not all, feel this type of anxiety that centers on now what and who is going to pay attention to my needs in post-treatment. And I also hear a lot of patients say that they feel in control when they're, actually able to actively treat their cancer with, chemotherapy or radiation. But then after the treatments, while waiting, weeks and sometimes months to, for scans and to see how, if the treatment was actually effective to get those results, they often feel out of control. And that, again, can lead to this type of anxiety. I let my patients know that I'm still available and that they can always call me and or come in for a visit for ongoing practical and emotional support. And I let them know that as long as they're a patient, I am still here for them, as well as their entire care team. We're not going anywhere. And so I encourage you to reach out to your care team for ongoing support if you start to feel any anxiety when you're finishing your treatment. The second area is sort of a combination of, was it worth it? Is it going to come back? And sort of this waiting game, if you will. Did the treatments have any effect? Was it worth putting my body and my mental state through the last number of weeks and months? Is the cancer gone? Is it going to come back? These are common questions that I often hear. And this is all going on, certainly, while people are contending with ongoing treatment side effects in post-treatment. Pain issues, memory and concentration, fatigue, taste and eating changes, talking ability, swallowing, dry mouth, et cetera, et cetera. So these are often also accompanied by, visible and non-visible body image challenges. People have scars or certain disfigurement, missing body parts, body function, et cetera. And these are all lasting reminders of your experience that present daily practical and emotional challenges. And again, I would encourage you to reach out to your clinical social worker and or care team in general to discuss any of these concerns. And during this waiting period, I often hear, why don't I feel better? And I often suggest that patients keep a diary, and nothing particularly fancy, just having a piece of paper, writing down a few things as they come to your mind, but tracking some of the positive, hopeful, if you will, small changes that begin to occur. It's really easy to focus on what is not improving to the exclusion of what is. And so when you write down what is getting better, even the slightest improvement of function, you can refer back to it. You have something tangible to look at. And it may help you start feel that something is getting better and not everything is bad. And it can be a helpful reminder that you are making some steps in your recovery. The third area I'd like to go into is sort of the non-cancer world, right? You've gone through all of your treatments, you've been head over heels in all that's been going on for you, and now all the treatments are done. Again, after having been so focused on, having regular scans, draw bloods, procedures, treatments, etc., it can be difficult for patients and caregivers and loved ones to make this transition. So, again, the questions come up, is it really gone? Can I go back to work? Can I start dating again? Can I go out with my friends and have a few drinks, etc.? Though treatments are officially done and the cancer, having been successfully treated, hopefully, you may struggle with this transition back to or moving on to the next chapter of your life. And your social worker can help by listening to and sort of exploring these concerns and providing direction on how best to address them. And during this transition, relationships are often challenged. You may hear from your spouse or partner or family and friends that, quote, it's over, now get back to normal. And or, you survived, it's done, now let's move on. You, having gone through all that you did, are still living the experience while everyone else wants to move on. They want to get back to normal, whatever that may mean to them. And this often leads to patients feeling separation anxiety, like we talked before, because your care team gets it, right? You've been around this whole team that does this day in and day out, and they understand what you're going through. So they get it, but your family and friends often don't. And this lack of understanding can cause strained relationships. In addition, due to your unique cancer experience, one sometimes develops a new outlook on life. And that can challenge not only yourself, but also to think differently, but also the relationships and life goals that you have. Living life differently can challenge this desired norm that family and friends wish for. They want to go back in time when you are moving forward. And then there are certain role changes that occur. And I see this a lot with the couples that I work with, where they're figuring out how the caregiver sort of becomes, again, just the spouse or the partner, issues of intimacy and sexuality. And there's often sort of new skills that need to be created or fostered. Partners and spouses may have to continue to develop these new skills and means of talking to each other as a way of better communication with the other in terms of ongoing caregiving, if there's needed caregiving. Certainly managing the household if the person who was sick is no longer able to do that. Child rearing, lots of different ways of interacting. And all of these can challenge the couple's relationship. When it comes to family roles, they're also impacted. When a loved one is unable to fulfill their role, for example, as a family leader or the initiator, maybe they were the planner or the organizer, maybe they were the breadwinner, the nurturer, the strength and support person, the one who others lean on for support. And when these temporarily change and or cannot return to the way that they were, they can lead to family dysfunction and leave the patient feeling alienated without this traditional role in the family. And it also impacts work roles. When it comes to work roles, you may find that you're not able to go back to work, or that work in the same capacity as before you were diagnosed. And work prior to your diagnosis may have meant a great deal to you. And so how are you going to negotiate this new work life? So these are some of the issues that some patients face in the post-treatment world. As daunting as some of them may sound, there are positive, healthy ways of addressing them. And that is where your friendly local social worker can come into play. So in conclusion, there's a lot of support available. Like I've been saying, your oncology social worker can certainly be effective in this way. We sort of help out with figuring out new coping strategies and finding appropriate resources and support to address these concerns. There are also numerous community supports that focus on patients with cancer that provide not only practical resources, but also individual and group support, emotional support. And many find that speaking with an individual counselor who has experience working with people who have cancer and or participating in a group with others who share a similar experience can be quite rewarding. So again, I hope that you'll reach out to your social worker and your care team for support. All right, so this sort of concludes our formal presentations. I'd like to open it up if there are any particular questions that anyone online would like to ask the panel. You can either write them in the chat or you can unmute yourself and ask them directly. I know there's a couple folks on, so if you have any questions, please feel free to address them to us.
Hi guys. Thanks, Darren. That you guys all did a great job. It was very, very informative and very helpful. When Brittany and Ashley and Alex were talking, it just brought me back to the importance of oral hygiene. And I think that needs to be stressed a lot because one of the, as we alluded to, one of the effects of the radiation on the oral cavity is changes that mucosa, and that dryness from the xerostomia from the radiation is long lasting. So one of the, it's very, very important to keep that mouth very clean. Additionally, our mouths are just dirty anyway. So if we're worried about any kind of aspiration or any food or liquid getting into your lungs as a result of while you're going through treatment, the cleaner your mouth is, the better it is, the safer it is for anything that may be going down the wrong way. So oral hygiene is going to be imperative both during treatment and throughout treatment as well. Also, with regards to the dryness, is that you're going to be prescribed fluoride trays during treatment that are going to be used daily, and that is something that you're going to want to really continue for the rest of your life because the changes inside that oral cavity with the radiation can be long lasting. And if you do require dental work further down the road with regards to any kind of tooth extractions or anything further, it's going to be really important that we try to keep that, those teeth as strong as they can be to avoid that, because that can cause problems further down the line. So oral hygiene, always, always. Water is the best as well. All right. And then quick question for Brittany. I have another comment for Darren is, does farro have good protein or is it just quinoa?
Farro, the
Yeah.
grain? It definitely has protein. But quinoa, I am almost positive, is actually the only grain that's a complete protein. It contains all the amino acids. But grains, like whole grains, do have some protein in them. Yes.
Okay. And do you need to eat a grain with a legume in order to get that complete protein?
Complete protein, yes, but you're still getting protein. It still counts. It just might not be as like bioavailable to your body, but it certainly still counts because most people aren't having just one food at one time. They're having a combination of things, and that combination generally reaches that complete protein.
Okay.
Yeah.
I don't like quinoa.
Oh.
And then, if this is either for Darren or maybe Andrew, I thought it was really interesting that you were saying, about, that post-anxiety, that post-treatment anxiety and with the separation anxiety. But I don't know if you have anything to add about, that initial surveillance scan anxiety that patients can deal with and that have to deal with, because I get that a lot in my follow-ups, is just, that no matter how far out they are from treatment, they still have that anxiety of that scan coming up.
Yeah, I mean, please chime in, Andrew. I mean, certainly, we hear this a lot, that first time, waiting that whole period until you get your first scan. And again, it can be on many weeks until that happens. And so it just builds and builds and builds. So not only do you have the physical, treatment side effects still lingering and playing their role in your body, you're also emotionally, thinking constantly, has this been worth it? Like, what is this scan going to show? Like, did I just go through all that I've gone through for nothing if this cancer is still there? Even if it's gone and the scan comes back really great, there's always that lingering thought, is it going to come back? Is it really truly gone? And so that level of anxiety shifts, it builds until that first scan, and then it can level off and kind of, spike and come back and forth when, every 3 months or every 6 months, whenever you're getting a new scan, or going in for blood results or whatever it may be. That always pushes people's buttons, and that can go on for the rest of your life at varying levels. You hopefully will build up, some good coping skills around that, and utilize Andrew, for example, as well as myself to help you in that regard. I don't know if you have anything else to add, Andrew.
So yeah, that's great, Darren. There's so many opportunities for patients to become anxious during diagnosis, during initial consults, up until the beginning of treatment, through treatment, after treatment. There are so many points of potential medically induced trauma, even just receiving a diagnosis of a life-threatening disease, which is one of the reasons why we have implemented a music psychotherapy program in radiation oncology, whereby we try and see all patients on their first day when they come in for a process called simulation. Those of you who are patients know exactly what I'm talking about. So simulation is sort of seen as the gateway to a big part of the process, treatment and healing process. And it's also been identified by our patients here as being the single most anxiety-producing moment in their treatment, surprisingly. We think that that's a huge statement. So we've spent a lot of time and effort designing and implementing a protocolized intervention that we try and provide for most patients. Unfortunately, you don't get to see all of them, but most patients that come in on their first day for simulation. And it is aimed at helping them lower their state anxiety, but also giving them tools to use during simulation, during treatment itself, and actually at home when they're feeling anxious, or if they're starting to enter into depressive states. They're also given tools to help address that as well. It is not the end of the world, but it's something to help our patients learn how to manage and actually flip that into being a productive state.
Thank you, Andrew.
And also, just one other thing that I want to say while I'm thinking about, I think we'd be remiss to say, is the importance of continued oncologic surveillance, no matter, for at least the first 5 years after your treatment. You need to be following up with your doctors so they can actually examine you both clinically and with scans at serial time. So, we're here in between. We're not only here from visit to visit, but those visits are very, very important as you heal and you try to put this behind you.
Ashley and Cindy and Alex, I have a question. I was thinking as you were talking, I'm wondering if there's something that you wish patients would tell you about sooner than later, or that they don't even think that might be important, but for you as a practitioner know that it's important to know about. There's something that sort of stands out that that patients don't talk to you about soon enough.
Well, I think that one thing is it happens especially as the adverse treatment effects start to set in. You ask patients at first, do you have any pain? And they're like, no, I don't have any pain. I'm not taking any medicine. And then you say, well, then why aren't you eating? And they say, well, it really hurts to swallow. And it's like, oh, that's interesting. And I think patients for some reason are thinking a lot of the times when everyone is asking them, do you feel pain? Do you feel pain? Do you feel this? Do you feel that? They're not thinking of a certain instance. They're thinking as a whole. And for us, it's like, oh, well, that's super important. If you're having pain when you're swallowing, that's something that needs to be addressed by a doctor. That needs to be addressed by the care team so that we can keep you swallowing and we can do what we have to do on the swallowing end. So I don't know if that's really what your question was, but it was just something that made me think of that.
Yeah, I think that's a good example. I mean, because of what patients have gone through this whole trajectory, and maybe their pain is less than it was during treatment by the time they see you, or like you're saying, it's this isolated pain and not this sort of global pain. They may not think to tell you about it, but for you and what you're doing to help them, it's really super important. So I was just thinking, like, if there were particular issues like that come to mind that you wish they would tell you sooner.
Yeah. And another thing, speaking to the pain and the pain management, like when you're going through treatment and post treatment, they're going to give you pain medicine to make it easier for you to swallow. But one of the things that's hard to for patients to wrap their heads around is that the pain medicine doesn't make the pain go away completely. It makes the goal of the pain medicine is to make the pain bearable to continue to eat by mouth and get your oral intake and get your nutrition orally.
Thank you. I have another question.
Yeah, I think there's
go ahead, Andrew.
To be made. Yeah, since we're on the subject of pain, is that what pain is about is pain management, and so often this is something that's lost sight of is that pain management is not necessarily or not every time about doing away with the actual cause of nociception is, what the actual source of the pain is, but about giving the patient resources, and that includes medication, to be able to get pain to a manageable level so that it's not hijacking their existence. Meaning it's not the only thing that they can actually focus on is the pain. So I think it's important that we are able to educate patients on what pain response is actually about and what pain management is and is not, as you're mentioning, Cindy. Really important.
Thank you, Andrew. Brittany, I had a couple of questions for you. One is, I often hear patients say, look, I'm overweight coming into my treatment. I know I'm going to lose some pounds. Woohoo! It's sort of like a diet time, and it's an easy way to lose weight. How would you address that? I know that we talk about having good nutrition helps you heal faster, but what would you say to someone who's like, hey, this is a great time for me to, shed 10 pounds? And the other question is, what I hear a lot is about what, are my taste buds or the taste bud changes that have occurred, are these going to be permanent? And, how am I going to enjoy eating moving forward? If you might want to address those.
Yeah, the weight management is definitely a good question because I do get that a lot. And the short answer is no, we don't want you to lose weight during this time, regardless of your pre-treatment weight. However, it's fairly normal and expected for most of our patients to lose some weight during the treatment, again, because it just can be so difficult to eat enough. But we base it sort of on a percentage of body fat loss and what we find to be like significant clinically concerning in terms of weight loss. And that's about more than 5% of your body fat loss, or excuse me, your body weight in a month would be concerning. So if you are, you know, a adult of average weight and height, and, you know, we don't want to see you lose 1 or 2 pounds every week, because that could become significant. So it really does depend on where your weight starts. But we do not support weight loss during this time. Your body is also tends to be hypermetabolic during treatment, meaning that you need more calories and protein than you might typically need. So it also can make you lose weight a little bit faster if we're not being very mindful of that. And fast weight loss often indicates you're losing some muscle mass, which we certainly don't want to happen. That can lead to other complications, including falls, if you're really losing a lot of weight, and interfering with your ability to continue your treatment. So I think that answered that question. And then with the taste, going back a little bit to what I did talk about, it is tricky, and I hope in the future maybe we'll have more studies on this. Some patients do have their taste come back 100%, and usually a year from their treatment, if not less, they can taste everything great again. They're enjoying all their food. Other patients, and it really depends sometimes on maybe the location of their cancer, the severity of their cancer, and whether they had chemotherapy and radiation or one or the other. Sometimes there are slight changes that last a lifetime, unfortunately. And I don't know if anyone else has a percentage on that. I don't, but it seems to really vary from patient to patient. But it isn't often so significant that you can't still enjoy food. You still can. You just might find that foods that maybe you loved, you might not love as much anymore, and foods that maybe you didn't care for, you actually might enjoy now, because those taste changes have occurred and some of them have sort of solidified. But generally, our patients do go back to really enjoying eating again.
Yeah, I would agree with that as well. I also think that if we're talking about post-radiation from after a surgery as well, that's going to impact the ability, how the degree to which the taste comes back after that. Fortunately, the radiation delivery models have become much more tailored and targeted. So the radiation oncologists are able to preserve a lot more of the taste centers in the oral cavity and the oropharynx. So we've had a lot more success with that coming back in the recent years.
Thank you, Brittany. Thank you, Cindy. I just have one other question for Andrew particularly. Can you share about how, if you work with patients that have all cancer types, and also if you work with patients only getting chemotherapy, your service?
Yes, absolutely. So we subscribe to the idea of continuity of care, which means that we try and follow patients throughout their entire course of treatment. If that includes surgery, chemo, and radiation, then we try and follow them through all three of those modalities. So I do receive referrals to help patients during their prep for surgery prep and anesthesia. So yes, short answer to your question, Darren, is yes, we work with patients in chemo and radiation, also inpatients, oncology.
Thank you, Andrew.
Yep.
Are there any other questions from anyone else who's on with us today, or from any of the panelists for the others? So if there are no other questions, we'll conclude our presentation. I'd like to again thank all the presenters and those of you who've joined us today. And we hope that the information provided will help you in your post-treatment care, and that you'll continue to utilize your care team for support. So thank you for joining us, and have a good rest of your day. Take care. Bye-bye.